Hello, everyone. It's Dr. Damon Ramsey broadcasting to you from Vancouver, Canada. It is approximately 1:47 a.m. on March 13th, 2020. It's a pleasure to be here with you today. And what I'm going to be doing is going through some technology-based solutions that my company, InputHealth, is offering to various stakeholders, community organizations, public health agencies, clinics, and basically any group, nonprofit or otherwise, which is seeking out technological solutions to help them in their response and planning and hopefully surveillance in the context of the coronavirus, COVID-19, and the subsequent pandemic response that our world is facing. It is, as I mentioned, quite late at night. I do not have the energy to edit this video, so I apologize beforehand on any mistakes that I make. Hopefully, those will be identified and addressed in the comments below this video. And without further ado, I should mention a little bit about my background. I'm a practicing family physician based out of here in Vancouver. I work at the University of British Columbia Student Health Service. As well, I am the physician for the University of British Columbia's Occupational and Preventive Health Unit. All that being said, the majority of my time is actually spent running a software company, which is called InputHealth. I'm proud that we have offices between Vancouver, Winnipeg, and Toronto. And as part of our response to COVID-19, we are actually contributing a lot of our team time, our technology and resources to anyone who's interested and willing to potentially utilize these tools in our efforts to conquer and hopefully reduce the burden of this pandemic that we face. Without further ado, I'm going to jump into the software that I'll be presenting. Just a little bit of context as I log in here on my account. In certain points of this presentation, I will be jumping to a patient view, and in certain parts, we will be focused on a provider view. We're currently in the provider view. I'm in a sample account. These are not real patient data points. This is all sample data that's populated in here. And as you can see, I've logged in as myself. And the platform that's in front of you is indeed a full health record and practice management solution. I will not be addressing functionalities of the collaborative health record, which is the name of our product. In general, things like prescriptions, billing, scheduling, all the typical stuff that you would imagine for electronic medical record style software. That is not my interest here today. What my interest is in showing you some of the more recent platform developments, some of which are still in beta. However, some of which I think are very relevant to helping us increase our capacity in the handling of this pandemic. Okay, so let's dive in here. First of all, I am currently logged in, as I mentioned, into a sample account. At a very high level, InputHealth supports multiple locations in one account. So I'm not going to spend too much time focused on the distribution of this software. However, I will mention that our software can run across geography, for example, across the entire country of Canada, with multiple locations for each province in one account, or theoretically, we can have separate accounts, all with their own subdomains, representing essentially different groupings of patients. The functionality that we're going to be focusing on is actually very innovative technology produced by InputHealth's co-founder, Sean Jung. I'll make a quick little reference here. Some of you might be familiar with Kanban principles, very common in project management. This was, I believe, originally developed out of Toyota, and it was designed to help facilitate manufacturing, lean manufacturing principles, and sort of helping process improvement in the context of processes which involve multiple steps from manufacturing to distribution. Why am I bringing this up? Kanban has become a very established project management, more general tool beyond manufacturing. And what we've done in our company is taken principles of Kanban and implemented them in the context of managing patient flow. We call this part of our platform workflow. And I'm going to be describing it from the settings. So right now we are looking at the back side of the system, not the front. This is where you would actually configure your system so that it could actually address the various permutations of your local environment. Okay, what I've gone ahead and done is produced an example schematic of a workflow dashboard. So here you have the settings page, as I mentioned, and over here, we actually have the workflow board itself. You'll notice that there are columns that are colored, and what you will see soon is that patients can actually be under columns, or what we call phases, and that represents the current state. So in a production environment, one would imagine that there would be potentially 100 people in triage, maybe 2,000 people under person under investigation. These phases basically represent these states, and what we want to do is transition essentially patients across a flow, never losing track of them. And I just wanted to highlight one of the reasons why we're particularly excited about applications of this technology in the context of our current public health crisis is we need to increase capacity, and we need to be in a world where we're taking advantage of automation and technology to avoid human problems being the reason for droppage. And so I think our current system is not appreciating the technological ecosystem, not just our product, but the many different products that can be applied so that we are not so dependent on humans who inevitably will be themselves quite a bit affected by coronavirus, COVID-19, and as well who are prone to make mistakes from fatigue and otherwise, as you will probably see in my presentation today. Okay, so phases. What I've done is I've gone into various guideline documents from major disease control centers, and I've roughly translated into this example schematic. We have initial triage, person under investigation, which has a definition that you can look up, hospitalized, home quarantine, exit testing, et cetera, et cetera. So I'm not saying we have to stick to this model. This was what I did sort of over the last 24 hours. It's been done without a lot of critical thought. It's been more about establishing an example, hopefully to engage with others so that we can refine this to meet local requirements. If I click on a phase like initial triage, it allows me to edit the settings associated with that. And one thing that's very neat about this system is you are able to allow certain transitions to other phases based on rules and processes. So I can go from initial triage to person under investigation. I can go from initial triage to low risk, not person under investigation, presumably a person who came through the triage and was decided to be not relevant enough to actually put them through the flow. Asymptomatic, high medium risk monitoring. So the person who sat next to a person with active coronavirus 19 on the airplane who's asymptomatic currently, but maybe for whatever reason we want to be monitoring them a little bit more closely in an automated fashion, and theoretically the ability to complete the visit right from the start. So if we went through triage and we weren't able to reach the patient at all, we might just want to end it because they're not actually part of the database. So these are the phases, and they have that functionality. Transitions basically allow us to define the movement between phases. So if I click on to home quarantine, this transition is a green colored one. That's simply for helping us track things. And one of the settings that's available to us is post actions, which basically means after this transition is applied, I want something to happen. And in this case, if we're moving the patient from theoretically initial triage, actually in this case, it would be from PUI to home quarantine, we can force the fact that the staff who's doing this should set up a daily monitoring questionnaire, which will be sent to the patient through their phone or email on a daily basis. So staff actions are things that we can define in another part of settings. And if you can follow along, it's a little bit tricky, but the idea here is that after I apply the transition, then please cue the staff so that they make sure that they do a certain task item that's part of the algorithm or flow. We can have multiple post actions. So I could actually, in the context of running this transition, automatically, for example, send a message to somebody indicating that this movement has occurred. So I'm not going to go into too much more detail there because I want to actually show you this from the front end. But basically, the concept that we have right now is we have these phases, we have these transitions, and this actually can enforce process so that, again, on a human level, we don't drop things, we don't lose people, we don't forget to do things that are essential in tracking patients. Staff actions. So these are things that we can define, as I mentioned. Make sure to fill out a form, upload a file, engage in chat, whatever it is. These are actions that we can define. This is a flexible system, so these things are not set in stone. And more interestingly, patient actions would indicate things that we want the patient to do in the context of transition through the flow. So watch hand washing video. So let's apply an example here. If I'm going to move a person to home quarantine, I could theoretically add a post action, which is assigning a patient action to watch the hand washing video. And I can require it or not, so there can be more soft or less soft in terms of these actions. So when I move someone to home quarantine, essentially the staff will be asked to set up a scheduled daily questionnaire, and the patient will be cued to watch a hand washing video, as I'll show you shortly. Patient contents. So here we're able to add in educational material, and then you can actually assign that as a task. For example, how to communicate your infected status at work. And then what we could do is provide a bunch of literature. And so if a patient is asking a question that we are frequently getting, we can add these as patient contents, and then we can actually push these through the app that I'm going to be showing you that the patient has. Okay. So, last thing before I actually move more to the front end side of things, we can have multiple workflow boards. So, sky is the limit, if you can imagine. This is a general sort of primary care or public health surveillance workflow, but we might have one for an acute setting, and we might have one for various different pathways, let's say addressing rural patients differently than urban patients. So we can have multiple boards. And going back again, this is the settings page. But if we want to see it more from the way it would look like to the provider, this is the workflow board. These are the categories that I've created. And now why don't we actually get a patient through here? So bear with me for a second. I am going to share my phone on the screen. Um, okay, so here we go. I've now opened up my phone, and for the purposes of this demonstration, I'd like you to think about the phone as the patient side. So I'm communicating with myself here, but really I want you to imagine that this person is remote, and I'm theoretically a family doctor who's hopefully working at home managing this crisis. So I'm going to go ahead and open up the app. This application currently is what we call generic, so it's not branded to any particular facility or clinic. This is again just for demonstration purposes, but I am going ahead and opening up this application, and I have basically already logged in as myself as a patient. And what I'm going to do is, as an initial sort of entry point, I'm going to go ahead and book a virtual visit for myself, and we're going to call that the initial triage virtual visit. So there are many different ways in which we can get patients into this workflow, but I'm just going to go in through the front door, knock as a patient, and I'm going to self-initiate a booking, which hopefully would be preventing a physical visit to a healthcare facility where I could potentially be unnecessarily exposing myself or exposing others to infection. So the scheduling system is connected directly based on the availability of a provider. And so I had set myself up to be working, as you can see here, very long hours, 6 a.m. to 7 p.m. on most days. And that's basically going to show me a live, on the patient side, is going to show me a live representation of my schedule. So I'm going to go ahead and book this appointment as a patient. Again, that's what's happening on the right side. And basically, the system is queuing a PreVisit questionnaire that has been developed so that we can actually get information prior to a visit so that we can be more efficient and have sort of discrete data inputted by the patients themselves. So who's filling out this questionnaire? It's myself. Do I have a fever? Let's say yes, it's above 38 degrees. Now it's asking me for symptoms. I have chills. I have shortness of breath. I don't have chest pain. I have cough, no fatigue, no runny nose, no sore throat, no digestive symptoms. I want you to keep in mind something as I'm going through this questionnaire. What's happening is we are organically creating our database. So those symptoms are going to be fed directly into an analytics database, which would allow us to track those symptoms without having to go through the usual nonsense of exporting data out. because this is all one integrated system. Have you been in close contact with a person who's confirmed to be COVID-19 infected? Yes, I have. These are just obviously fake answers. I was recently, in an airplane. Have you traveled outside of Canada or been in close contact with a sick person who has traveled outside of Canada in the last 14 days? I'm going to go ahead with no there. Describe your household type. So this whole questionnaire I just built based off of some intuition on essentially how we can actually risk stratify people. So obviously there's a difference if we know that this is a multi-generational household where I live with my grandparents versus if I'm a one-person household. So let's go ahead and say multi-generational. What kind of housing do you live in? We're in a detached house. I am a healthcare worker. Again, that would be a very relevant data point to track because we are the ones that are actually going to be at the front line of this or are at the front line of this. Do you have any additional information you would like to share with us? Should I be tested for C19? Okay. So one thing I want you to notice here is that essentially this appointment that Damon, the patient, filled out versus the provider, which is on this side, it actually, without any refresh needed, put this card or ticket into the workflow board. So that was not there. If you rewind, that was not there a few minutes ago. And so I want to go from the provider side, and we'll park the patient for a second, which is what you see on the right side here. And what we're going to do is, myself as a doctor, I'm going to go ahead and transition to the start phase. So we now have moved Damon's visit on the right side here into a progress. So this is an active patient in our flow now. And you can see that ticket is in this column. So you can imagine there might be 5,000 patients running down this list. We can organize it by various filter criteria, but for now, there's only one, and let's see how this works. So Damon's come in as a patient, seeing myself, Damon as the provider. I should have used different names, but bear with me for a second. He's been waiting 41 seconds. I'm going to go ahead and open up his particular encounter chart. And I have the ability to go through and see various data points that could potentially have been filled out, letters that have been sent, forms that have been filled out. At this point, the system is actually popping up and notifying me. Of course, I sneezed into my hand there. I just want to confirm that I'm not in a public environment, and I will be washing my hand very shortly. Maybe that part I will edit out of the system. But just moving back to the software here, what's happening here is the system is saying that Damon filled out this questionnaire, and he wants to alter the data points in his profile to the ones that are shown here. So as a provider, I can go ahead and accept this, which means that we have a gateway from which we can validate the data points that are coming in from the patients. I could also go in and change it. So if I know Damon really well, and we were just talking on the phone, and I found out he actually does have diarrhea, I could actually go ahead and change that, and it would be logged accordingly. But let's go ahead and apply these data points. So essentially, one thing that's very nice about this is that the patient has actually populated a lot of their risk profile themselves, which is fantastic. And this is tracked. So we know that the patient filled in that data, and that I, as the provider, accepted it. So we're going to do that initial triage. Now, I have the ability to go in here as a provider and start chatting I have the ability to start chatting, and if you can see on this side here, that's Dr. Ramsey in a very schizophrenic fashion, communicating with himself. Yes, I am here. So we have, sorry, I should respond from the patient side. Yes, I am here. So that's myself responding. So we have now, in the context of this active progress workflow encounter or case, we have a live chat communication that's secure. That is, in the case of our Canadian database, fully meeting the requirements for the privacy regulations here in Canada. We have the equivalent in other countries as well. So you can see here, that's awesome because now we actually have a tracked record and I can actually chat directly back and forth. Uh, a lot of people are interested in video visits, and I would submit to you that video visits are fantastic in certain cases, but can also be quite obstructive in certain cases. So if, I'm talking to a millennial. I might be comfortable actually reviewing the questionnaire and providing advice through chat. Based on your answers, I am going to move you into X category. Uh, uh, and I'm just going through an example here. Bear with me. In this case, actually, he is high risk, I believe, based on the way that I answered those questions, which I can go and review here, by the way. So this is showing those answers that Damon has completed. I'm able to look at those answers very clearly. If I had time, I could actually assign a scoring mechanism into this questionnaire so that we can clearly see risk more obviously. We can color code these answers based on risk. But at the end of the day, his screening questionnaire, he's got fever, he's got contact with confirmed C19. All roads lead to one, which is that we're going to move Damon into person under investigation category. So let's go ahead and do that. Remember, these available transitions were defined by myself on the settings side. So to PUI indicates you're awaiting screening results for this patient. So really, I should have an action which initiates me filling out the requisition and submitting whatever process that is to get that sample from the patient. But you'll notice if I close that screen, we've now moved initial triage. We've moved Damon from that phase into PUI. And so if you're getting the concept here, I'm not going to bore you guys to death with the whole process, but we now have a few things. We have a direct channel, secure channel of communication with Damon the patient using this app. If I close it and I go in here as the provider and I send him a message, it will come in as a push notification, and that will take him back into the appropriate screen. So that's fantastic. We're not using WhatsApp. We're not using iMessage because we're tracking this data. We are storing this in a health grade, secure fashion, and we're logging it and timestamping it, and it's all encapsulated in one platform. So these things are great. On the other side, we have a full tracking system here for you. So if you're a public health unit, if you're a primary care practice that's been assigned this by a public health unit, we don't need to guess where our patients are because we've put them into this flow and it has rules. And basically, I can't just go and delete this record. I can only move it into certain phases based on certain rules, if you'll remember. So this is the way that we actually enforce process and avoid droppage or breakage, which can result in terrible outcomes in our society. I can go in here while Damon's person under investigation. Let's assume we open up his files. He has a lab result that's come in. He's positive for COVID-19. At this point, I'm going to move him to home quarantine. Now, this is neat. If you notice on the patient side, now he's been assigned a task where my mouse is. Watch hand washing video. How awesome is that? So, the patient's been assigned this. Now they're, watching this nice video from the CDC. I'm going to stop that. And I'm going to move this back over here. So we can see that the patient actually opened up the video. And if I had made it required, it could actually validate whether he watched the whole video from the beginning to the end. And if he doesn't, then it won't allow me to move him to the next phase if it was required. So how great is that? On the other side, set up daily monitoring questionnaire. So as a provider, this is still not done. So I can go in here, and I'm actually going to set up a questionnaire daily, every day at 8 a.m. Delivery method is patient preference. I want him to do the active daily monitoring questionnaire. And we have settings here where if he doesn't actually do it, then it will alert someone. So we don't have excuses for losing contact. How great is that? That's fantastic because, again, there's these rules built into the system so that we don't lose track of people, which I think is a big problem in the context of surveillance and management of this pandemic. So I'm going to go ahead and click save. Now we've actually completed that task. And so that would allow us to move to the next available transition. I've been talking a lot longer than I expected here, and I apologize if it's a little bit rambly. I hope you can sense my excitement. The excitement is based off of the fact that I feel what we've built here is an effective way to encapsulate a virtualized model of tracking patients. I think it's quite innovative and unique. I think that this could be used in multiple different settings. I think that it should be used in multiple different settings. And I want to especially make a shout out to countries or regions that have less resources, to environments where people are particularly vulnerable. We welcome you to reach out to us and request a plan on how we could potentially set this up for your environment. I'm dedicating my entire team to focus on how we're going to contribute to reducing the suffering that will come from, or that is coming from this particular virus. Lastly, before I jump off, you'll notice that the patient filled out a questionnaire. In this system, there is an entire platform which allows us to build questionnaires. So this over here gets translated into the available patient-facing tool, or it could even be provider-facing, frankly. So we can build these in multiple languages. We can build new ones that are addressing different problems, and these all get encapsulated into your account in one integrated end-to-end solution for managing these patients. That's one thing. Secondly, for the data geeks out there, I really want the system to organically produce my database. So when you answer a question, it is able to update the actual variable in the backend database based on rules that you set up. So that's the way that we organically build the database. And lastly, there is an entire analytics platform, which I'm not going to show you right now. Maybe I'll make a follow-up video with one of my analytics people. But basically, all this data that's being collected is immediately pushed into another database, which allows for aggregate analysis and visualization of that data. So if you're a public health agency or group that's dealing with this, we're really giving you that packaged workflow. This questionnaire here, active daily monitoring, which will come to me now every day because that's what I set up. This is actually pulling this, which is what our Center for Disease Control has provided, which is a piece of paper, which is not sufficient, into a technological solution that is available, that is producing a database so that we aren't guessing as much about symptom patterns. So if you hear me getting a little bit passionate there, it's because in 2020, I don't want to see this. I don't want to see a piece of paper that is on the computer, which is what a PDF is. I want to see this, and I want to see how easy it is to distribute this to the relevant people so that we have the data to make good decisions. That's what our system deserves. And that's what the ecosystem around us is made available. All right. That's all she wrote for now. As I mentioned, please reach out if you have any questions about this platform. We are considering this a crisis, and it is our obligation and duty as citizens of Canada and citizens of the world that we do everything in our power to reduce the amount of suffering that we're going to be seeing soon. My name is Damon Ramsey, as I mentioned. Please reach out if you need to. You can. I'm hesitant to give my email online here. I think the best way to reach me would be through Twitter. My Twitter handle is Damon Ramsey MD. I'll put this in sort of below the YouTube video, and we can go from there. Thank you very much, everyone, and looking forward to working on solving these issues together.